Hello everyone, I am Rachel Lowe from Physiopedia. I am absolutely delighted today to be talking to Ken Olson. Hello Ken.
Hello Rachel, thanks for having me here today.
Oh Ken, you're welcome. I am looking forward to talking to you. We do these talks with leaders in our profession quite regularly, and I like to draw out your knowledge and your clinical tips for clinicians to share with everyone around the world in these conversations. So before we do anything else, I was wondering if maybe you could, as we do with everyone, introduce yourself to, just tell us a little bit about yourself and what you get up to for people that have never met you before.
Okay, well thank you, Rachel. Yes, so I'm a physical therapist in the United States. I'm in private practice, so the majority of my day is treating patients in the clinic, and so I'm president of an organization where we have 4 clinics in northern Illinois. I also do some part-time teaching at some local universities with entry-level students in particularly teaching how to examine and treat the spine. And so that's been really kind of my clinical research and teaching interest has been more the spine. So that led to publication of a textbook a few years ago, and the second edition just came out in 2016. On a professional organizational standpoint, I'm also pretty involved. I'm a past president of the IFOMPT, which is the manual organization in the U.S. that's the member organization to IFOMPT. And then I've also served on the IFOMPT Executive Committee over the last 8 or 9 years, and recently took on the role as president. So that also keeps me pretty busy in my spare time.
I can imagine that does all keep you busy. So that's quite a really nice rounded profile. Practicing clinician, educating, also in organisation governance, and a book author. So your book, Manual Therapy of the Spine. So you released the second edition last year, 2016. Yeah. Tell us a little bit about the book.
Well, it really it gives the foundational information that a physical therapist would need in order to do a comprehensive examination and treatment of the spine. It's really designed for entry-level programs that want to incorporate manual therapy and manipulation and exercise into the curriculum for management of spinal conditions. So there's chapters on each region of the spine, as well as the TMJ, so the temporomandibular disorders is also included. And there's also video clips with it. So it's kind of, it has the evidence to support the interventions, as well as a detailed description of manual therapy techniques and exercises, and then also video clips that go along with description of the various examination and treatment procedures.
Awesome, very useful. I really like it when people do video clips with the books. They can be really useful to help visualize the techniques that you're talking about in the books, and that's really useful. How many it's my understanding there's quite a lot of videos with this book.
Yeah, there's about 200 video clips, and we filmed those at Marquette University, where I do some teaching, and Guy Seminole, who was the past editor of GSPT, was quite instrumental in helping me put these together. But we had 3 cameras going through most of the filming, and so Guy kind of helped, decide which angle looked best as I was up there demonstrating the technique. So they came out quite useful with nice visualization of the various techniques.
Good. Now I want to home in on the cervical spine. And I want to delve into some of your knowledge about cervical spine. So I know there's a full chapter in the book, isn't there? Like you said, it's divided up into areas of the spine. So in the cervical spine, what for clinicians that are working with individuals with neck pain, what's the key knowledge and key skills that they need to have to effectively work with an individual with neck pain?
Well, I think the first thing is to do a good comprehensive examination, and a big part of that is the history taking, and really taking the time to try to get to know your patient. And besides the obvious things of what makes your pain better, what makes it worse, but also just kind of what's going on in the person's lives and how this is impacting them. So I think that's the first thing. That also becomes part of your medical screen along the way, just to make sure that what they're telling you makes sense from a musculoskeletal standpoint, and that you're not missing some sort of serious pathology. So, and that's where the IFOMPT framework for screening the cervical spine is quite useful in kind of pulling together sort of some of those clinical decision-making key points that are important for the screening. And then, moving forward into the tests and measures, I think it's important to, I was trained in a very biomechanical approach, so I still kind of look at the spine in that way, trying to figure out, like, where is it moving too much, where is it not moving enough, that sort of thing, but also considering how the muscles are functioning and how well they're controlling the spine. And then as we get into the manual exam, just trying to get a sense of, like, how irritable or reactive the tissues are, because that's going to impact, how you might apply the manual therapy techniques. And then, the real trick is kind of pulling that all together and then trying to sort out, what's the primary condition, what's secondary, where can we really focus in initially with the treatment to make the most impact, and then what do we need to do more long-term to try to really rehabilitate that individual.
Okay, so you mentioned the IFOMPT screening tool, which we will share with this video now that you've mentioned it, and it is an awesome tool. I know a lot of IFOMPT spent a lot of time on that tool, and it should be used by every clinician that is working with individuals with neck pain. You mentioned that as a key part of the examination. Are there any particular, and this might not be an appropriate question, and you can tell me if it's not, are there any particular tests that are key in the physical examination? We've talked about the sort of subjective examination, how the importance of asking questions and getting the full history and the screening. Are there any sort of key tests, if clinicians were to become excellent at a few key tests, are there any particular that they would be?
Yeah, well, that's the challenge with the screening exam, is that a lot of the tests for vascular pathology or even instability, which are kind of some of the key things you're sort of looking to screen before you initiate any sort of manual therapy intervention, the reliability and validity of those is really kind of somewhat questionable. So, so it's hard to say, there's not really like one test that really nails it for you. It really is sort of looking at the whole picture of the patient, trying to sort out if it makes sense that this is a musculoskeletal condition that should be treated. Now, having said that, there are some things that orthopedic manual physical therapists oftentimes don't do as part of their exam that they really should, that can really build some safety nets into what you're doing. And one of those is a good neurovascular screening, essentially. So doing a good neurological screen, looking at cranial nerve function, and also checking the blood pressure, because that is a tool we have that oftentimes those blood pressure cuffs are sitting off in the corner getting kind of dusty, and we need to bring those back into our examination rooms and use that as part of our screening, because that certainly could be a sign that there's a serious risk factor there for some type of vascular pathology that may have been missed before the patient got to us.
Okay, so interesting, bringing blood pressure back in and the screening tests and the neurovascular screening as well, really important. So that kind of rules out any conditions that we should be concerned about, I guess. So say we've ruled out all of that, what do we do from there?
Okay, so we've ruled all that out. We're pretty convinced that now this is a musculoskeletal condition that we can treat, and again, a lot of the direction of the exam will depend on what the patient's telling us with the history. So, do they have an element of headache or dizziness along with the neck pain? Do they have radicular signs and symptoms going into the arm? Is the thoracic spine perhaps involved? So we're certainly going to, kind of screen all those things by, looking at posture and range of motion and things of that, screening seeing how the shoulder moves in relation to the spine. And then we just then the direction of the exam is kind of varies depending on, what we're finding at that point.
And I think what you highlight there actually as well is the importance of knowing how different conditions present as well. So it's important for us to have that sort of basic understanding or recognition of patterns that different conditions present with, because that will give us a clue as to what we're looking at when we do the examination.
Correct, yeah. So, kind of the foundation of my approach is like an impairment-based approach. So ultimately, I'm interested in finding, does certain region of the spine maybe move a little too much, or other regions not move enough, and then, are the muscles controlling the movement efficiently or not, and then directing very specific treatment, either exercise or manual therapy, to kind of correct those impairments. So that's kind of really the foundation, but then the symptom behavior and the individual patient condition is going to dictate what other things we may add in, whether, again, if it's more radicular or nerve tension, we're going to be screening for that. If it's more very acute and like post-whiplash type of condition, then we're going to be very cautious and using very more non-provocative sort of manual therapy interventions. So yeah, we try to really kind of tie in and make it very eclectic, pulling in what the literature supports for the different types of conditions.
Absolutely. And your approach, you've mentioned how you would adjust your approach for different types of conditions. So for example, the whiplash that comes in, how you would adjust your approach for them who's probably more sensitive, more irritable, however they might present. And your approach is being a president of IFOMPT, and with the book you've written, it's a manual therapy focus. Are there any sort of other techniques, modalities that you use in your practice when working with individuals with neck pain?
Modalities, such as like...
Modalities, approaches, interventions.
Sure, okay. For the vast majority of my patients, it's primarily very specific exercise and manual therapy techniques. And then, if a patient has, occasionally I'll put a hot pack or a cold pack on somebody, but I really don't pull out a lot of other like electrical modalities and that sort of thing. So yeah, it's pretty much focused on, using the manual therapy techniques, soft tissue and joint specific techniques, combined with specific exercise. That really continues to be what I'm trying to do, as well as sort of being cognizant of what's going on with the patients, psychologically what's going on with them a little bit, and just trying to understand, trying to incorporate some, a little bit of, I'm not an expert on sort of the modern pain science type of things, but I do try to incorporate some of those principles also in terms of how I counsel my patients and try to get them to understand, their perception of their pain and how other factors in their lives are impacting it. So, so much of what we do is talking to our patients, but I'm talking to them while I'm doing the various, manual techniques too.
Yeah,
so it's all great.
Definitely. And I think that fits the picture of how we might be able to approach any individual, doesn't it, with any patient that comes to see us. So it's about, what do we have? We have communication as a key aspect, biopsychosocial, always paying attention to what else is going on, and communication helps on that side. And then manual therapy, hands-on approach that we have, that we are very skilled in, and then exercises as well. You mentioned exercises, so they're always important, aren't they, as part of the big picture of us working with individuals who come and see us. Do you have any advice for people around specific conditions, or are there any sort of approaches that are better for specific conditions, or are there any, or is it just about looking at the patient as they present in front of you and seeing what you find?
Well, certainly that is, a big theme. I think sometimes young clinicians also might forget about the thoracic spine, and the importance of, there's some pretty nice studies, emerging evidence that shows that manipulation of the thoracic spine can help with with neck pain. And so oftentimes in terms of just, that sort of quick hitting sort of thing that, you can kind of sort of jumpstart the rehab a little bit, and just get people moving better, feeling better. There again, depending on how reactive things are, but oftentimes going to the thoracic spine first and trying to free up the thorax and the soft tissues, all through the rib cage, thoracic spine. And then, doing work through the shoulder girdles, exercising that way, oftentimes can have a really nice impact on what's going on with the neck, So that is kind of sort of taking, sort of some of the evidence that shows that works, but also sort of thinking of biomechanically, just getting things moving through the whole region. And so, like I said, it's just kind of a nice way oftentimes to get started with patients, is get that thoracic spine moving.
Yeah, good. And with regards to, there's two things I want to ask you. There's two things on my mind at the moment. One is about, so we've talked a lot about manual therapy techniques, and they certainly have their place when we work with, particularly with people in the spine, as you've just mentioned. How do we become skilled manual therapists? If you know what I mean. Do you know what I mean? Apart from reading your book, of course, and watching your videos, do you think, what can physiotherapists do to become really skilled at using manual therapy techniques, particularly in the spine, in the cervical spine, where we need to be careful and things like that?
Well, that's a good question. I think certainly, there's coursework out there that, and, whether it's weekend courses, seminars, that sort of thing that can kind of help get you started. In the United States, we've actually tried to, push to get more manual therapy and manipulation integrated into the entry-level programs, and that has kind of helped give a pretty good foundation to the therapists coming out. But to really be skilled, you really need kind of you need to learn kind of a series of courses perhaps can help, but then having a mentor who can work with you in the clinic side by side with the patient is really by far the best way. So you need to be able to have those practice sessions away from patients with the watchful eye of a good mentor, and then hopefully they can join you with the patient on occasion also, and kind of just kind of give you that feedback. So, I mean, really to learn a psychomotor skill, you need practice and you need feedback. But then to really kind of incorporate that mentoring in a clinical environment. So, there's certainly, there's some wonderful online resources also that can be helpful, and you want to try to keep up on the evidence and see what's coming forward in terms of what's being supported. But ultimately, it just comes down to sort of building those skills and being able to develop, rapport with the patient, and then, kind of using some finesse in kind of how you use the manual therapy interventions, and kind of having a mentor nearby can really help.
Yeah, I think that's the thing, isn't it? We can all read a book and watch some videos. It's the actual feedback that we're getting on our techniques that's quite important, isn't it?
Absolutely.
Yeah. And so the other thing I want to ask you about is clinical decision making in the cervical spine. How can we improve our skills in that area? Is there anything we can do to help us with clinical decision making?
Yeah, well, that's a pretty broad topic. Rachel.
Yeah, I know. Well, I'll bring it down to the cervical spine. Yes.
I think it's kind of everything we've talked about really so far, so I don't know, it's really, it's a matter of spending the time with the patient, and so much of it comes down to the history and asking the right questions, and listening to what the patient has to tell you, and hearing their story, and I think, in the United States at least, there's sort of a tendency to, do a quick exam and then sort of delegate and, have, physical therapist assistants do a lot of the interventions. And I think, we're sort of missing the boat with that a bit. I think it really needs to be the process of taking a good history, doing a good examination, and then continuing to re-examine the patient as you treat them, and monitoring their response to the interventions, and modifying your approach based on their response to your treatment. So like I said, it really just needs to be that one-on-one, understanding the patient, and trying to listen to them and sort of interpret what they're telling you, and responding to that each time you see them. So there's no real simple answers to that. It's just you have to put the time into it.
I think so. I think one of the things that helps us with that clinical decision making is to always bear in mind, there isn't a particular treatment pathway, a care pathway for a particular condition that someone presents with, because everyone presents differently, everyone's an individual, and every condition, whether if they're suffering the same thing or will be different. So you should always bear in mind that they're an individual, like you said. And then I guess the other thing is having a good knowledge base. You can't make those decisions without a good knowledge base. So making sure that you have the knowledge, just like we mentioned before, of being able to recognise certain conditions, and the patterns that they present with, and things like that. So that's all really important as well. Would you say that's correct?
Yeah, I absolutely agree.
Yeah,
yes.
Yeah.
And there is, there are ways you can sort of classify patients and kind of help guide some of the overall management of the patient. But you're absolutely correct that even within that, there's going to be variations, and it really, each individual has their own set of things going on in their lives, as well as what's going on, from a musculoskeletal standpoint, that needs to be, sort of considered and addressed as you work with them.
Yeah, and it's difficult. It's difficult to build those clinical reasoning and clinical decision-making skills, but it just comes with experience, doesn't it? And again, that mentor would be a help as well.
Absolutely.
Yeah. Okay. Is there anything about the cervical spine that we haven't talked about that you would like to share that might be really useful for clinicians that are working with individuals with neck pain?
Boy, I think we've done a pretty good job of covering things. I think I probably would just still want to emphasize that process of getting to know the patient, and sort of looking at their individual needs, and just sort of in responding to those needs as you continue to examine it, and treat the patient and re-examine them as you go. So I think that would be sort of my key message.
Really important, and I think that highlights again communication, and how we need to be skilled in communication, and being able to draw out the information from our patients so that we can respond to that appropriately and effectively. Ken, it's been really good to talk to you about cervical spine. I think we've had some really good tips there on how to approach individuals with neck pain, some of the really important things that we need to look at, like good history, good assessment, so initial assessment, reassessment every time we see the individual, the screening processes that we need to do before, so and the IFOMPT screening process and the neurovascular screening processes that we need to do before we actually go on and treat the patients with the interventions that we have at hand to work with them. So it's been really good to share your knowledge and to dig that out. I hope everyone will find something useful in there to take into their clinical practice. Ken, where can we find out? We'll add a link to the book, which is Manual Physical Therapy of the Spine by Elsevier. We'll add a link to that. Where else can people find out more about you and what you get up to?
Okay. I guess I think going to the IFOMPT website, certainly to see what IFOMPT is up to, International Federation of Orthopedic Manipulative Physical Therapists, so ifompt.org. Certainly there's things there in terms of what we're doing with IFOMPT as an organization. in terms of, myself promoting, it's really just my clinical practice is called Northern Rehab. So northernrehabpt.com in DeKalb, Illinois. But in terms of, other than that, I'm not really promoting myself a whole lot, Rachel.
That's totally fine. I think there's plenty of places for people to find you there, and I think, and whenever there's a big conference on, Ken is always there as at the moment as IFOMPT President, but we always seem to bump into each other at conferences, and it's always good to meet with you again. So Ken, thanks so much for having a chat with us today. It's been really good and really informational. Thank you very much.
Okay, thanks for having me. I enjoyed it.